So our next presentation is Dr. Jensen Ang. If you can please share your screen there, Jensen. And I'm fascinated to see, now remember, you only have 20 minutes because I'm fascinated to see how we can get all of the common neurosurgical emergencies in about 20 minutes, but off you go. Well done.
Hey, hi everyone. My name is Jensen. I'm one of the senior residents here in NNI. I will be talking about common neurosurgical emergency today, but I chose this topic because I feel that as a junior resident or someone starting out in neurosurgery, it's helpful to kind of know what to prioritize and look for. So what we're going to cover today really wouldn't be the whole, comprehensive variety of all neurosurgical emergencies, but we're just going to focus on 4 main scenarios: so injury, hemorrhage, hemorrhage, as well as hydrocephalus. And essentially, what we hope to establish at the end of today will be to have a systematic approach to event and management of these neurosurgical emergencies. So first and foremost, I think what we need to remember is that the brain needs these 3 things in order to function. So oxygen, glucose, as well as perfusion. And ischemia or irreversible injury can occur if any of these factors become inadequate. So going back to what my colleague Dr. Chong mentioned last week in his talk on ICP, the Monroe-Kelly doctrine highlights an important principle, and that is that the skull cavity is a fixed space. It's filled with brain, CSF, and blood. And any expanding space-occupying lesion first decants CSF and then venous blood. And once it starts to decant arterial blood, that's when our patients start to decompensate and to deteriorate clinically. I will get back to this later on in my presentation because it's important in terms, especially in terms of traumatic brain injury. But the principles of management of all neurosurgical emergencies really will be to evaluate the patient, predict the possible consequences based on the degree and the type of injury, and then treat them before the consequences become irreversible. So let's start off with head injuries first. Traumatic brain injury constitutes a major cause of death and disability in all ages. And this incident has been steadily increasing both in the developed world as well as developing countries as a result of increased motorization as well as an increase in force. And the important point in history taking would be the mechanism of injury as well as whether the patient experienced any seizures prior to getting to the hospital, because these factors could provide clue as to how the patient would eventually progress. In terms of examination, I think the important point would be the GCS and the pupils. Now we can do a much more comprehensive history if the patient was well, but given that this is an emergency, you want to focus on the most important parts that will help you make a decision quickly. In terms of investigation, we definitely need a CT hit. So just a quick discourse about the GCS. The important point to remember is that it is the indicator of global and not focal brain function. And the problems include that it has a high variability between observers, and there are many ways that people do grade it, test it and grade it, but the key point would be that you have to use a stimulus that is central and cannot be influenced by spinal reflexes. So using a sternal rub or supraorbital notch pressure will be far better than a peripheral state pain stimulation, for example. You should also take the best response in an adequately resuscitated patient. And problems aside, the GCS is actually a very useful indicator, especially the motor component, on how badly the brain is damaged. So going on to traumatic brain injury, once we have done the evaluation of the patient, we go on to essentially classify the types of injury that has been sustained. And here I have split them mainly into 2 categories. So primary injury as well as secondary injury. Under the localized categories, you have fractures, vein tears, contusion, and ICH. You also could have diffuse injury. I mentioned it as diffuse injury because we only get the diagnosis of diffuse external injury in a post-mortem examination. So we will just call them diffuse injury for initially. And if these potential factors are not treated or addressed, then they could go on to lead to result in secondary brain injury. Okay. So traumatic brain injury is unique in the sense that in an injured brain, it reacts very significantly to only a very minute change in oxygen or glucose levels or perfusion. And therefore, ensuring adequate oxygenation and perfusion to the brain at all times is very important. So the first question that you'll be asked would be whether or not the patient has to be intubated, whether the airway has to be secured. If you remember the pressure volume curve that I showed earlier, as arterial blood volume starts to decrease because of the buildup of space occupying lesion or the intracranial pressure, it could still be the ICP could still be normal, but the patient could already be becoming drowsy because of ischemia. So the most reliable indicator of how injured the patient's brain is still a clinical assessment of his GCS. If we pop an ICP, if we sedate the patient, the ICP helps in terms of measurement, but it only responds a bit later compared to clinical deterioration. And therefore, in this case, it's a balance between wanting to protect the airway before hypoxia sets in a traumatic brain injury patient versus the ability to assess the patient GCS when he's not intubated. And therefore, if we are considering when to intubate the patient, I think the strong indicators would include a low GCS of less than 8, a deteriorating GCS, a rapidly deteriorating GCS, because eventually you know that the patient is going to end up not being able to maintain his airway and hypoxic. If there's already signs of hypoxia or if the patient suffers from a seizure. Now, relative indications would include scenarios where the patient is very combative or agitated, or if, let's say, you are actually planning to move the patient from a location to another, for example, on his way to the operating theater, then you could electively, not say electively, but you could elect to intubate the patient earlier to kind of secure the airway before the transfer. And then finally, if there are other external injuries that could cause the patient a great amount of discomfort, and you will need to keep the patient sedated or under strong anesthesia, then you need to be mindful of the side effects of these medications and possibly elect to intubate them early as well. But otherwise, management of a head injury patient is relatively straightforward. We ensure good oxygenation, so we intubate if necessary to protect the airway and respiration. We ensure good perfusion to ensure that there is normal blood pressure and no ongoing blood loss. And then essentially we control the pressure within the skull. If there's a focal lesion that is causing significantly raised ICP, then surgery should be done to evacuate it. If it's actually just mainly diffuse swelling that is causing a rise in intracranial pressure, then my colleague Dr. Chong, I think, addressed this adequately. We manage it using our 3 tiers of ICP management. So that's it for head injury. I'll move on to ICH next. So intracerebral hemorrhages is a very common problem that we see in our institution here. It accounts for 20% of all strokes, and its incidence is also projected to increase with our aging population in Singapore. So in the history itself, we want to find out the time of onset, if there's a history of high blood pressure or hypertension, and if there was any prior use of antiplatelet or anticoagulation. When examining a patient, I think the GCS as well as the focal deficit that the patient has will be the key finding to pick up, because it gives you clues as to where this clot is actually located inside the brain. And investigation of choice here is the CT brain as well. Now, there are many causes, but I think what I'm trying to point out here is that hypertension as well as amyloid angiopathy in the elderly are the 2 main causes of intracerebral hemorrhages that we see here. The other less common causes, such as the MCA aneurysm rupture, tumors, AVMs, or even venous sinus thrombosis, they do occur, but they are less common. And essentially, intracerebral clot should be regarded as an acute life-threatening event because even if presenting symptoms can initially appear mild, hematoma progression can lead to rapid neurological deterioration. So the presence of a clot would in turn also cause edema around it, and the ensuing hemoglobin and iron toxicity as the clot breaks down eventually also causes death of neurons around it. So if the hematoma size is significant, it will also exert significant mass effect to the surrounding brain parenchyma, and that also causes ischemia. So the key aspects to managing intracerebral clot really is to stabilize the patient's vital functions. Then we identify and treat the underlying bleeding source. That there will be a need to control any kind of elevated intracranial pressure, and then we institute specific treatments to limit hematoma progression. So, for example, we keep the BP under control to reduce the risk of hematoma expansion. We also treat any coagulopathy. In our practice here, we tend to give platelets for patients on antiplatelets. We reverse any kind of prolonged clotting time as well. And then finally, the question of whether surgery is needed will have to be answered. So, which brings us to the question why we should operate on an intracerebral clot. Now, as you can see here, just by having an intracerebral clot, it starts a whole cascade of events. And therefore, if it's likely that the clot size and the expectant edema that ensues, if it's going to cause significant mass effect as well as herniation, or it leads to significant brain injury around it, then evacuation of the clot actually reduces the likelihood of these happening. So we've kind of identified 5 main factors when selecting appropriate surgical candidates. They are namely age, the hematoma size, the patient GCS on admission, the location, as well as their clinical course. I think this is quite straightforward. We tend not to operate on the very old. If the patient is very well, or if they are already showing signs of brain stem herniation, posturing, for example, then we do not operate on them as well. If the clot is extremely small, or if it's massive, then we do not operate on them. If the location of the hematoma is very deep, maybe even within the brain stem or in the thalamus, we do not operate on them. And finally, looking at their clinical course, if they were well throughout, there's no indication to suggest an operation. If they were already moribund from the beginning, then I think the operation might not also benefit the patient. That was in the case of a supratentorial ICH, and in infratentorial ICH is quite similar. Yeah, I think the additional point I wanted to highlight is that given that in infratentorial ICH, usually a cerebellar clot, if it's not within the brainstem, sometimes the posturing could be just a sign of direct compression on the brainstem pyramidal tracts. So in these cases, sometimes it is beneficial to offer surgery because rapid removal of this compressive effect actually more often than not the patient do improve. And then finally, another kind of rationale for offering an operation would be if the clot is actually causing obliteration of the fourth ventricle, leading to hydrocephalus. So in those cases, we could either elect to take out the clot if it's massive, or if it's small but still causing significant compression to the fourth ventricle, then a ventriculostomy will help. Now let's move on to SAH now. So patients with a ruptured aneurysm could die before they reach the hospital. They could also present merely with symptoms of a sudden onset headache, nausea, vomiting, or drowsiness. So the key point during evaluation of these patients will be the GCS and the presence of motor or speech deficit, because that influences your WFNS grading. CT will provide information based on the distribution of the bleed, whether there's a presence of intracerebral clot, such as in the case of MCA aneurysms itself, or whether there's the presence of hydrocephalus, which would necessitate ventriculostomy. And then moving on, in our institution, we very commonly elect to do a CT angiogram at the same time. because that gives us a rapid diagnosis as to where the aneurysm is. The consequences of the aneurysmal subarachnoid hemorrhages are as follows. So sometimes patients do get very significant cardiac stunting from the catecholamine surge and also neurogenic pulmonary edema. Hydrocephalus is a possibility. In the ensuing hours to days, then we start to get more worried about a re-rupture of the aneurysm. And seizures, electrolyte abnormalities are also some of the more common consequences that we see. And then finally, in the ensuing days, delayed ischemia due to vasospasm can also occur. So the two kind of main grading scales that would be very helpful in terms of predicting the patient prognosis as well as the likelihood of vasospasm would be the WFNS score, as shown here, as well as the modified Fisher scale. And management of good grade patients is quite self-explanatory. Essentially, we are managing the consequences of a ruptured aneurysm. And so cardiac stunting and pulmonary edema sometimes require intubation or inotropic support. In the case of hydrocephalus, we put in a temporary EVD. If that persists despite after a few weeks, sometimes we have to shunt the patient. And then rebleed of the aneurysm is initially controlled by close control of the blood pressure to make sure that it's not too high. And then eventually we have to think about coiling or clipping the aneurysm to secure it. Once the aneurysm is secured and we start to raise the blood pressure, increase the hydration in order to prevent vasospasm and delayed ischemia. We also sometimes provide some intraarterial nimodipine infusions in the case of patients who go into symptomatic vasospasm. Now, the management of poor grade patients a little bit more contentious. So they have a poorer prognosis, and therefore one of the things that we know can complicate GCS assessment could be hydrocephalus. So if there is acute hydrocephalus, we will put in an EVD, and we will see whether the patient improves. If they improve to the good grade, to the good grade criteria, then we could go ahead and treat the consequences of SAH just as before. But in some of the cases, without any improvement, sometimes we would opt to palliate them. Now, there's a few special circumstances in SAH, and they tend to apply more to the grade 3 hemorrhages. So sometimes patients who are initially good grade, but they have an MCA aneurysm rupture resulting in a clot can present with hemiplegia or hemiparesis. Now, in these cases, if the clot is actually causing significant mass effect, then there is a plan to actually evacuate this clot, then clipping can be done at the same time as well. Now, if the hemiparesis or the dysphagia was due to ischemia, however, then we will aim to secure the aneurysm as quickly as possible, either through coiling or clipping, followed by instituting hydration as well as high blood pressure in order to reduce the extent of ischemic deficits. And finally, moving on to hydrocephalus. I think this is quite self-explanatory. The symptoms include headache, nausea, vomiting. On fundoscopy, you might find papillary edema. And I think the main kind of special circumstance to highlight would be if the patient had previously had a shunt, because the shunt malfunctioned very often. And so if we were suspecting a malfunctioning shunt, then these are some of the investigations we can consider. So a shunt series X-ray to make sure that there's no disconnection or kinking of the shunt tubes. We can do a shunt tap to see whether or not the proximal portion is actually still patent. And finally, we can consider CSF infusion studies as well. So that brings me, management, I think, is quite self-explanatory. Essentially, we have to relieve the hydrocephalus either through a temporary EVD or a more permanent shunt insertion. That brings me to the end of my presentation. I think I've covered the main kind of nuances and priorities in head injury, ICH, SAH, as well as hydrocephalus. And just to remind us that medical treatment is mainly about predicting the consequences and treating them before they become irreversible. Thank you very much, and I hope to answer any questions you might have.
That's a great picture. Jensen, I really liked your, I hate to make you go back, but can you go back one slide, even as much as I like that picture? So I think when you see, you know, when you see a lot of junior residents or interns see patients, they get to the evaluate, but the most important next step in the development of becoming a neurosurgeon is to predict the consequences. And that's, I think, the real cognitive jump from being able to just examine the patient and say what you see, to examining the patient, understanding the disease, and knowing what will happen next and do something about it. So I really like the way that you've put that out there. I've got an interesting question here. When the patient is intubated, do you always ventilate or just give oxygen? I think that's probably most of the time you'd ventilate, but any sedation or muscle relaxant given to intubated patients?
I think that depends on the status and the condition of the patient. If we want to keep the patient minimally sedated in order to assess them clinically, then we basically give a minimal dose of normally fentanyl so that they can tolerate the tube. And essentially, we keep them minimally sedated so that we can assess the GCS. If it was a scenario where we wanted to control what we know to be high or raised intracranial pressure, then sedation actually the first step in the management that we institute in our institution in order to address the ICP.
Yep. And one other question, is there a role for TXA in intracerebral, so tranexamic acid in intracerebral hematoma?
No, there isn't. But we are actually doing that for some of our SAH cases as well over here.
Okay. All right. Thank you, Jensen. That was a tour de force of 4 important conditions in about 20 minutes. But as I said, the 2 most important slides were your boss kissing a skull and which I think is fantastic, and the predict that, you know, what's going to happen next after the evaluation. The number of times I get called in the middle of the night by someone who says, oh, I've got a patient with this and this and this and this, and it's a beautiful evaluation. Then it's like, okay, and next. And that's the next step that's so important to get straight in your own mind.